Chapter, chapter 31, chest injuries. This chapter will look at the recognition and management of blunt versus penetrating mechanisms, open chest wound, impaled object, the pathophysiology assessment and management of blunt versus penetrating mechanisms, hemothorax, pneumothorax, open simple, or tension pneumothorax. We will also be looking at cardiac tamponade, rib fractures, flail chest, and commotio cordis. Traumatic disruption, pulmonary contusion, blunt cardiac injury, and traumatic asphyxia. Introduction. Thoracic injuries are common and very severe. Injuries interfering with normal breathing must be treated immediately. Internal bleeding, blood from lacerations of the thoracic organs or major blood vessels, collects in the chest cavity. Air can collect in the chest and prevent the lung from expanding. So if air collects in the pleural lining, it can cause the lung to collapse. Prevention strategies include gun safety education, sports training, the use of seatbelt. Thoracic trauma accounts for a significant number of injuries and fatalities each year. Now let's review the anatomy. Thoracic cavity extends from the lower end of the neck to the diaphragm. The mediastinum is the central region of the thorax, and this is a space where the heart and major blood vessels occupy. Muscles of the thorax help to protect the underlying organs. The intercostal muscles and the diaphragm are the main muscles of respiration. The sternocleidomastoid muscles are accessory muscles of respiration. The trapezius, rhomboids, and latissimus dorsi muscles provide the covering for the framework of the posterior thorax. The pectoralis major surrounds the rib cage in the front. The trachea is the middle of the neck and it supplies air to the lungs. The lungs occupy the entire thoracic cavity except the mediastinum. The esophagus enters the thorax via the thoracic inlet and travels through the posterior of the chest. The nerves supplying the diaphragm exit the spinal cord at C3, C4, and C5. Hence the saying, between C3 and C5 keeps the diaphragm alive. Paralysis of the muscles paralysis of all muscles before the shoulders is possible if there's damage in that area. If there's damage in that area, it can affect the ability of the diaphragm to move, which is important to the process of ventilation. And there can be a loss of sensation from the shoulders down if there's damage in that area. Ventilation occurs through expansion and contraction of the thoracic cage. Intercostal muscles between the ribs contract, diaphragm contracts and descends, and this causes exhalation. When we exhale, that is positive pressure. Let me rephrase that. So ventilation occurs through the expansion and contraction of the thoracic cage. Intercostal muscles between the ribs contract and the diaphragm contracts and descends. This is inhalation, so that's negative pressure. Exhalation is the reverse. The intercostal muscles and the diaphragm relax. Tissues move back to their normal position. Pulmonary respiration. Blood is delivered via the pulmonary circulation. Oxygenation. Delivery of O2 from the ear to the blood. The ability to pump blood depends on functional pump, adequate volume of blood to be pumped, and a lack of resistance of the pumping mechanism. Cardiac output, the volume of blood delivered to the body in 1 minute. Ventilation is a process of removing CO2. Chemical changes influence the rate and depth of breathing. Chemoreceptors respond to chemical fluctuations. Rising CO2 levels are mediated by influence on the central chemoreceptors of the brain stem, which respond to changes in the pH as a result of too much CO2 in the cerebrospinal fluid. Rising hydrogen ion levels inside central chemoreceptors into action. Respiratory alkalosis is the result of hyperventilation, and respiratory acidosis is the result of hypoventilation. So respiratory acidosis is always related to the body's inability to remove CO2. So there is too much CO2, which is forming carbonic acid, which is causing the pH to drop, which the cells cannot function. In that environment, it can shut down the brain. Changes in arterial pH can modify the respiratory rate and depth. Ventilation changes occur in response to changes in pH detected by the peripheral chemoreceptors. Metabolic alkalosis, respiratory rate and depth decrease in an attempt to retain CO2 and lower the pH levels. So respiratory acidosis is compensated with metabolic alkalosis, and respiratory alkalosis is compensated with metabolic acidosis. Mechanism of injury. So let's look at the pathophysiology. Mechanism of injury in thoracic trauma, blunt and penetrating. Types of chest injuries, closed, skin overlying injury remains intact. Visceral injuries may occur. For open, the chest wall is penetrated by an object. Blunt trauma. Blunt trauma may result in fracturing of ribs, the sternum, or whole areas of the chest wall. There may be bruising of the lungs and the heart, and the aorta can be damaged. Skin and chest wall are not penetrated. The broken ribs may lacerate the intrathoracic organs. Vital organs can be torn from their attachment in the chest cavity without any break in the skin. Blast injuries may be classified as blunt or penetrating. Shock wave during primary blast compresses organs similar to blunt trauma. During the secondary phase of blast injury, objects may be thrown and penetrate the body. Thoracic trauma may impair cardiac output, decreasing blood pressure, cause decreasing blood pressure and perfusion to the organs. Injury to the chest can be lethal. Trauma may result in blood loss, pressure changes, vital organ damage, or a combination. Bleeding into the thoracic cavity increases chance of hypovolemia and hypoxia. Increased intrapleural pressure decreases lung volume and oxygenation. The blood in the pericardial sac compresses the heart. Vascular disruption may occur due to trauma. Impairments in ventilator efficiency may also be rapidly fatal. So if there is something that is affecting the ventilation or the movement of blood, it can be fatal for the patient with chest injuries. Air exchange and subsequent oxygenation decreases with injury to the chest, bellows. Patients with severe chest pain tend to breathe shallowly, which reduces minute volume. Air may enter the pleural space. In pneumothorax, the space is created between the two pleural surfaces. In hemothorax, blood accumulates between them. Atelectasis may also occur, the alveolar collapse that prevents the use of the lung for ventilation and oxygenation. It significantly reduces the surface area available for gas exchange, and gas exchange is reduced with the alveoli. It also provides more surface area for bacteria to invade the lung. Bruised lung tissue may produce marked hypoxemia. Disruption of respiratory tract prevents oxygen from reaching the alveoli. Now, signs and symptoms of chest injury. Important signs to look for. Pain localized at the site of injury that is aggravated by breathing. Bruising to the chest wall. Crepitus with palpation of the chest. Dyspnea. Hemoptysis, which is coughing up blood. Failure of the chest to expand with inspiration. Rapid weak pulse and low blood pressure. Cyanosis around the lips and fingernail bed, and remember that cyanosis is a late sign. Change in breathing after chest injury is an important sign. Inadequate breathing is fewer than 12 breaths per minute or more than 20 breaths per minute, and you will link this to the patient's level of consciousness. So when looking at the breathing to determine if it's adequate, look at the patient's level of consciousness, their breathing rate, rhythm, quality, and depth. Patients with chest injuries often have tachypnea and shallow respiration. Patients may present with bradypnea and labored respirations. Dyspnea is caused by airway obstruction, damage to the chest wall, improper chest expansion, lung compression. Hemoptysis, spitting or coughing up blood, indicates lung parenchyma or damage. Air passage. Blood may enter the bronchial passage. So hemoptysis indicates damage to either the air passage or the lung tissue. The presence or absence of pulse. Rapid weak pulse and hypotension are signs of hypovolemic shock. Absent radial pulses is severe hypotension. Tachycardia may indicate compensatory shock or hypoxemia. Changes in blood pressure, hypertension, result of increased sympathetic discharge. Hypotension, sign of hypovolemia, relative hypovolemia, or late shock. Increased pressure on the myocardium will result in a narrow pulse pressure, which is the difference between the systolic and diastolic. Loss of peripheral pulses during inspiration, that can be linked to pulsus paradoxus or cardiac tamponade. Diaphoresis and pallor accompany peripheral vasoconstriction. Cyanosis is a sign of inadequate respiration, and it is a late sign. Now, the patient assessment. First, start with the scene size up, scene safety. Ensure the scene is safe for you and your partner or you and your crew. Use appropriate personal protective equipment. Identify how many patients, if necessary. Perform triage, which is sorting patients based on priority. Request any additional resources needed. Consider the need for spinal motion restriction. Once you have completed your scene size up, the next phase is your primary survey. This is where you will address live threats, assess and address live threats. Form a general impression. Know the patient's level of consciousness. Responsive patients may be able to tell their chief complaint. Perform a rapid exam for obvious injuries, the appearance of blood, trouble breathing, cyanosis, irregular breathing, chest rise and fall only on one side, accessory muscles in the neck while breathing, extended or engorged external jugular veins, which indicate back pressure in the chest, specifically the major blood vessels in the mediastinum. Initial general impression is important. Check for spinal injuries. Penetrating wounds in the neck and the position of the trachea should be checked. Check for adequate breathing. With chest injuries, begin by inspecting for decap BTLS and look for equal expansion of the chest wall. Look for retractions. Absent or decreased breath sounds on one side usually indicate significant damage to a lung. Check for paradoxical motion, and listening for breath sounds is very important to these type of patients. Listen early. Immediately cover any open wounds with glove hand and apply an occlusive dressing to all penetrating injuries. Administer oxygen via a non-rebreather mask at 15 liters per minute. Pay close attention to any changes in the patient's mental status. Auscultation of heart sounds is a part of the circulatory assessment. Hyperresonance, tympanic drum-like sound that generally indicates the presence of ear. So hyperresonance is loud. Hyporesonance is dull sound that generally indicates a solid or fluid rather than ear. So when it's ear in the pleural membrane, lung sounds tend to be loud. When it's fluid or solid, the lung sounds would be dull. Jugular vein distension suggests increased intravenous pressure. Lack of JVD in a supine patient may suggest a hypovolemic state. After the primary survey is completed, the next phase of the assessment is the history taking. So investigate the chief complaint and MOI and obtain a history of the present illness, obtain a history of the patient's mental status and dyspnea, chest pain associated with symptoms such as other areas of pain or discomfort, comfort and symptoms before the incident. History of cardiorespiratory disease, use of restraint in an MVC, any medications the patient may be taking. Investigate associated signs and symptoms and pertinent negatives. Palpation of the chest causes direct pain. Does palpation of the chest cause direct pain? Verify where the pain was located in relationship to the area being touched. Pertinent negatives in chest examination, no associated shortness of breath, no rapid breathing, no absent or abnormal breath sounds, no areas of deformity or abnormal movement. Obtain a sample history. Complete a basic evaluation of symptoms, allergies, medications, pertinent medical problems, respiratory or cardiovascular disease, and last oral intake. Identify events leading to the emergency. Questions about the events surrounding the incident should focus on the MOI. So when obtaining history, you're going to focus on the chief complaint. So you need to get information on the presenting problem. Make sure you identify your pertinent negatives and obtain your full sample history. This information can be obtained directly from the patient, bystanders, family members, or you look at the scene or the patient for clues. If you're not able to obtain information from the patient scene, from the patient, or gather appropriate information from bystanders or family members or friends, then it is important to check pupils, check blood sugar, and pay attention to pulse oximetry and end-tidal CO2 values for this patient. After the history taking, next is the secondary assessment. Look for signs with the potential to compromise the management of the ABCs. In case of isolated injury, focus on the isolated injury, the patient's complaint, and the body region affected. Look for ecchymosis and other evidence of trauma while assessing the skin. Repeat the rapid full body scan, looking for decap BTLS. Obtain a full set of vital signs if not done earlier. Use your diagnostic tools to evaluate the effectiveness of respiration or the respiratory system. So use your pulse oximetry, use your end-tidal CO2, capnography, waveform capnography, get the patient on your cardiac monitor, do a 12-lead ECG, if necessary, establish IV access, and initiate fluid resuscitation if necessary. After the secondary assessment, reassess the patient vital signs, oxygenation, circulatory status, and breath sounds. Reassess the chief complaint, communicate with hospital staff early when the patient has a significant MOI to the chest, have a complete and thorough documentation. In your reassessment, reassess your ABCDEs or XABCDEs. Look for trends. Is the patient trending up or trending down? Do you need to make adjustments with any management? And ensure that you document your findings properly and notify the receiving facility of these findings that you would consider to be significant for the patient. Emergency medical care, stabilizing the ABCs. Evaluate the patient's airway and respiratory status while maintaining cervical spine immobilization if necessary. Provide assisted ventilation using a bag valve mask device with high flow oxygen. Use caution to avoid increasing the patient's work of breathing and pain. Treat for shock and provide rapid transport if patient has signs of hypoperfusion. Establish IV access. Establish at least one large bore IV catheter and administer a 20 ml per kilogram bolus of an isotonic crystallite solution. Titrate fluid administration to a systolic blood pressure of 80 to 90 or 90 to 100 if you suspect internal bleeding. Rib fractures. Upper four ribs are well protected by the bony girdle of the clavicle and scapula. So if they are fractured, it requires significant force to do that. A fracture is a sign of a very severe MOI. Morbidity and mortality rates will be high based on the type of force applied to cause this fracture. A fractured rib may lacerate the lung surface, resulting in subcutaneous emphysema, which is here under the skin, which is outside of the respiratory system. Ensure to relay this finding to the hospital personnel, and it is going to be caused by blunt force trauma. Atelectasis decreases the surface area for gas exchange, results is a ventilation perfusion mismatch, and this will lead to hypoxemia. So once atelectasis is present, there will be an issue with the exchange of oxygen to the blood. So the blood is going to be coming from the right side of the heart and not be properly oxygenated because the alveoli has collapsed, or the alveolar has collapsed, and this will cause a ventilation perfusion mismatch. Severe trauma to the first and second ribs may result in ruptured aorta, tracheobronchial tree injury, and vascular injury. With a posterior fracture, 5th through 9th ribs are most frequently injured. The floating ribs are well protected and rarely fractured. Rib fracture puts the patient at risk for multiple injuries. Managing rib fractures focuses on managing the ABCs and evaluating the patient. Flail chest. A chest wall segment may be detached from the thoracic cage, producing a free floating segment, which results in paradoxical motion. Prompted by significant chest trauma, mortality rate varies. It may lead to a pneumothorax or hemothorax. Chest should be exposed and examined for decap BTLS. Management of flail chest is to first assess the need for positive pressure ventilation, then administer oxygen. So the use of bulky dressing to hold down the flail segment is no longer practiced. The best management is going to be to take over the patient's ventilation. Blunt force trauma that causes the flail segment can also produce a pulmonary contusion. Sternal fracture occurs in patients experiencing blunt chest trauma. Enough force to fracture the sternum may also result in pulmonary and myocardial contusion. Can also result in a flail chest and other injuries. Presents localized pain and tenderness over the sternum along with crepitus on palpation. Difficulty breathing is a very common finding with these injuries. Clavicle fracture occurs most often in children when they fall on an outstretched hand. Patient will report pain in the shoulder and will usually hold the arm across the front of his or her body. Fractures of the clavicle can be splinted effectively with a sling and swathe. Commotio cordis. The thorax receives a direct blow during a critical portion of the heart's repolarization phase. So trauma to the chest occurs at a point where the ventricle is filling with blood and the electrical impulse is about to pass down into the ventricle, and it disrupts that electrical activity and the patient immediately goes into cardiac arrest. This is referred to as commotio cordis. It leads to immediate cardiac arrest. The patient may present with ventricular fibrillation. Patients may be cyanotic, leading to tonic-clonic seizures. Survival rates depend on CPR and AED access. Simple pneumothorax. Air enters through a hole in the chest wall or the surface of the lung as a patient attempts to breathe, and it causes the lung to collapse. The amount of pneumothorax that develops varies. Spontaneous pneumothorax is possible in a patient who experiences sudden sharp chest pain and shortness of breath without a specific known cause. Patients may present with tachypnea and tachycardia as a result of hypoxia. Excuse me. Chest wall movement decreases as pressure increases, and hyperresonance, which is caused by ear, can be detected with percussion. Immediately cover an open wound with an occlusive dressing. We don't seal all 4 sides because we don't want to trap air in the pleural space. So 3 sides. Repeated assessments are important. So we need to monitor this patient to ensure that they are not developing a tension. Call for paramedic backup for treatment of potential cardiac dysrhythmias and/or attention pneumothorax. Open pneumothorax occurs with penetrating trauma to the chest. Open injury in the chest wall allows pleural space to communicate with the atmosphere, limits development of negative intrapleural pressure, and results in collapse part of the lung. So rarely an open pneumothorax will become a tension. Hypoventilation results from increased pressure and decreased lung surface area available for gas exchange. Hypoxia occurs as less oxygen is available for gas exchange. Air enters the pleural space during inspiratory phase. Negative pressure draws air into the lungs and through the opening in the chest wall. Direct lung injury may occur if the lung parenchyma was penetrated. The vena cava may become kink from swaying of the mediastinum as pressure builds. That's when it starts to become a tension. Note presence of defect in the chest wall or penetrating injury. Sucking chest wound, open or penetrating wound to the chest wall. Tachycardia and tachypnea increases in relation to the level of the patient's difficulty breathing or respiratory distress. Treat sucking chest wounds immediately. Injury should first be converted to a closed wound injury. Place a glove hand over the injury, replace it with an occlusive dressing or a commercial chest seal. When using an occlusive dressing, record the type of material used, whether 3 or 4 sides were sealed, any changes noted in skin color, vital signs, breath sounds, level of respiratory distress. Burp dressing if patient presents any signs of increasing distress or any signs of developing a tension. Tension pneumothorax results from blunt or penetrating trauma. Classic signs: absence of breath sound on the affected side, unequal chest rise or paradoxical motion or asymmetrical movement of the chest, pulsus paradoxus, tachycardia, dysrhythmias. Increasing pressure within the thoracic cage leads to accumulation of blood within the great vessels just outside the thoracic cage. Patients may report pleuritic chest pain and dyspnea. A normal blood pressure suggests when other signs of attention pneumothorax are present, focus on maintaining the ABCs. Inspect the chest and cover any open wounds with an occlusive or non-porous dressing. If signs of developing tension are present, then lift one corner of the dressing to allow air to escape. In case of a closed tension pneumothorax, call early for paramedic backup to perform a needle chest decompression. Hemothorax occurs when potential space between the parietal and visceral pleura is violated and blood begins to accumulate within this space. Results from tears of the lung parenchyma, penetrating wounds that puncture the heart or major vessels within the mediastinum, blunt trauma and deceleration, shearing of major vessels, rib fractures and injuries to the lung parenchyma or tissue. It is a life-threatening injury. Massive hemothorax. This is the accumulation of more than 1,500 mils of blood within the pleural space. As blood accumulates, the lungs collapse. Dependent on amount of blood in pleural space, hypoxia results from decreased gas exchange. Hypotension and inadequate perfusion may result from the blood loss. Present signs and symptoms of shock. Decreased breath sounds on the affected side will also be present. Hemopneumothorax. Pneumothorax with ear and bleeding in the pleural space. Findings and management are the same as for a hemothorax. Manage the ABCs, that's your priority. Administer oxygen and positive pressure ventilation as needed. If hypovolemia is present, establish IV access, the largest IV that can fit, and start your fluid resuscitation, 20 mils per kilogram or 30 mils per kilogram, depending on your protocol, and maintain a systolic of 80 to 90 or 90 to 100, depending on your protocol, if the patient is bleeding internally. Once you have established the amount of fluid that you're going to administer, remember we give the fluid in increments. After each increment, reevaluate the patient's level of consciousness, pay attention to your lung sounds, especially for your pediatric population, the presence of a peripheral pulse, and the color of the skin. Also pay attention to your pulse pressure and your mean arterial pressure. Pulmonary contusion. Most common injury from blunt thoracic trauma. Suspected in patients with a flail chest, imperative to maintain a high index of suspicion based on the MOI. Mechanisms for pulmonary contusion include implosion effect, overexpansion of air in lungs secondary to pressure wave causes blunt trauma, inertial effect, strips alveoli from heavier bronchial structures when alveoli are pulled by the pressure wave, Spaulding effect, liquid gas interface or exchange is disrupted by the shock wave. Alveolar and capillary damage from these mechanisms causes interstitial and intra-alveolar hemorrhage. For large contusions, the body compensates by vasoconstricting pulmonary blood flow and increasing cardiac output. Pulmonary shunting decreases functional reserve capacity and leads to mixed venous blood being returned to the heart. Pulmonary contusion continued. Auscultation may reveal wheezes, rhonchi, rales, or diminished breath sounds in the affected area. Treatment for pulmonary contusion is supportive. Give only small amounts of IV fluid to improve cardiac output as needed. Cardiac tamponade. Blood or other fluid collects in the pericardium, the fibrous sac surrounding the heart. Pericardium attaches to great vessels at the base of the heart. It has two layers, the visceral pericardium, which directly attaches to the heart tissue, which forms the epicardium. You have the parietal pericardium, which is the sac itself. Purpose, it acts as an anchor for the heart and it prevents kinking of the great vessels. The space between the layers can hold 30 to 50 mils of fluid. Accumulation of fluid over minutes leads to increase in intrapericardial pressure. Fluid amounts as small as 50 ml can cause reduction in cardiac output. Ischemic dysfunction may result in infarction. Removal of as little as 20 ml may drastically improve cardiac output. Cardiac tamponade can occur in both medical and trauma patients. Essential to assess and manage the ABCs, initiate large bore IV access and provide rapid fluid bolus to maintain a systolic blood pressure at 80 to 90 or 90 to 100 millimeters of mercury, depending on protocol. Pericardiocentesis is the ultimate treatment. Myocardial contusion, bruising of heart muscle. Vascular damage may occur. Fibrinous reaction at contusion site may lead to delayed rupture or ventricular aneurysm. Right or left side heart failure may also be present. Clinical signs may vary based on the area of injury. Myocardial contusion continuing. Patients may present with retrosternal chest pain and may or may not show external signs. Crackles or rales may be heard on auscultation. Provide supportive care, which would include administering oxygen, frequently assessing vital signs, and establishing IV access. Assess for JVD and pulmonary edema. Acute perforation of the ventricles, atria, intraventricular septum, intra-atrial septum, chordae tendineae, papillary muscles, and valves can also occur. Causes of myocardial rupture. Severe blunt force to the chest compresses the heart between the sternum and the vertebrae. Penetrating injury to the heart. It is a life-threatening event. Patients may present with acute pulmonary edema or signs of cardiac tamponade. Traumatic aortic disruption. This is rupture of the aorta. Aortic aneurysm burst. The aorta includes three layers, the intima, media, and adventitia. Assessment findings would include retrosternal or interscapular pain, dyspnea, dysphagia, hoarseness or stridor, ischemic pain of the extremities, upper extremity hypertension with absent or decreased strength of femoral pulses, systolic murmur over the anterior surface of the body. Penetrating wounds of the great vessels, usually associated with injuries to the chest, abdomen, or neck. Large blood vessels contained in the chest include the superior vena cava, inferior vena cava, pulmonary arteries, four main pulmonary veins, aorta, and its branches. Wounds to any of these may be accompanied by massive hemothorax, hypovolemic shock, cardiac tamponade, enlarging hematomas. Hematomas may cause compression of any structure. Immediate transport to the hospital is critical. Management includes maintaining ABCs. Diaphragmatic injury may be a result of blunt or penetrating trauma. Healing process is inhibited by the natural pressure differences between the abdominal and thoracic cavities. High pressure compression to the abdomen leads to increased intra-abdominal pressure, which can be transferred to the chest. Can lead to bowel obstruction and strangulation, restricted lung expansion causing hypoventilation and hypoxia, cardiac and respiratory compromise from mediastinal shift, injuries separated in 3 phases: acute, latent, and obstructive. Signs include tachypnea, tachycardia, respiratory distress, dullness to percussion, scaphoid hollow, boat-shaped abdomen, bowel sounds in the affected hemithorax, decreased breath sounds, provide positive pressure for hyperventilation. Esophageal injury. Penetrating trauma is the most frequent cause. Spontaneous perforation may occur in violent emesis, carcinoma, or anatomic distortions produced by diverticular or gastric reflux. Patients typically present with pain, hoarseness, dysphagia, respiratory distress, shock. Signs of cervical esophageal perforation includes local tenderness, subcutaneous emphysema, resistance of the neck, unpassive motion. If perforation is in the intrathoracic esophagus, signs may include mediastinal emphysema, mediastinitis, subcutaneous emphysema, mediastinal crunch, splinting of the chest wall. Prehospital care is supportive. Manage the patient's symptoms. Tracheobronchial injury usually result of blunt or penetrating trauma. It has a high mortality rate. The site of injury is often close to the point of attachment. Injury to the trachea or mainstem bronchi allows for rapid movement of air into the pleural space, so the patient can develop a pneumothorax very quickly. Associated findings include tachypnea, tachycarditis, massive subcutaneous emphysema, dyspnea, respiratory distress, hemoptysis, signs of tension, pneumothorax that do not respond to needle decompression, hoarseness. So they will actually be rapidly developing a subcutaneous emphysema, not necessarily a tension pneumothorax. But with this rapid development of subcutaneous emphysema, they will present as if they have a tension pneumothorax, which needle decompression will not fix because of the severity of the injury. Traumatic asphyxiation or asphyxia. Sudden severe compression injury of the chest produces a rapid increase in intrathoracic pressure. A sudden compressional force squeezes the chest and blood backs up into the head and neck, causing jugular veins to engorge and capillaries to rupture. Present characteristic appearance. Ocular hemorrhage may be mild or extremely dramatic. Hypotension occurs when pressure is released. Early recognition, a rapid transport are key. Patient will require aggressive airway management. Treat symptoms, position appropriately, ventilate as needed, and you may have to consider advanced airway intervention. Take cervical spine precautions, obtain IV access with 2 large bore IV lines. And that would bring us to the end of this chapter.